So you'll notice that through all this talk about creating the pressure gradients, creating a lower pressure within the lungs, drawing air in, then relaxing, and creating a higher pressure gradient within the lungs, forcing air back out. It is essentially a one-way in-out system. It has to come through the upper airway. Yes, there is the nares and the nasal passages and the oral cavity and the oral passages, but they all connect in the pharynx to create one pathway into the lungs. So it is a controlled system. If for some reason that system becomes uncontrolled or breached, in the case of something like a sucking chest wound or where a chest cavity has been breached, the chest wall has been breached, so now there's a hole here. And that hole goes into the now created an uncontrolled pathway for air to come in outside of the lungs, which can severely disrupt what's going on. So when the chest expands and we're creating that larger area, that is now allowing air to come in through that hole, and it is not necessarily going into the lungs, it's going into the thoracic cavity, which does us no good. And that will continue to force this, the more it happens, pulls air in, the more this happens, the more this lung in this area here will start to get air, and this lung will eventually start to fall in on itself, will eventually start to collapse, because this air may not be able to make it back out. In either case, this side of the lungs, or this side of the chest that has the breach, is not functioning as well as the other side. And if allowed to continue, can make it impossible to have ventilations. So it's important to know, and we'll discuss more on this in another lecture, but it's important to know, as part of your assessment, if there is any wounds in the chest, any breaches in the chest wall that are allowing air to come in and out. The mechanical ventilations are controlled by the pharynx nerve that controls the diaphragm and signals the diaphragm when to contract. This occurs automatically, like we discussed earlier. This happens without us even thinking about it. We breathe 10 to 12 times a minute on our own, on average, every minute of every day for 75, 80 years. That number goes up and it goes down depending on what we're doing. If we're sleeping and we're not expending energy, we have no increased oxygen demand, our respirations may slow slightly. Or when we're awake, we're active, we're running, we're exercising, we're doing whatever, our respiratory rate or our ventilation rate will increase due to oxygen demand and recruit more lung tissue for ventilation and deliver what the body needs. We can control this voluntarily. As I said earlier, we can increase our own respiratory rate. We can slow down our respiratory rate. We can stop breathing to a point. The body will protect itself. That's why we pass out. The automatic response to the levels of oxygen and CO2 within the blood, as sensed by the hypothalamus. And then, of course, again, voluntarily, as I said earlier. We can control it faster and slower depending on what we need. We will get more into that as we get more into oxygenation and such like that. Okay, so now we're going to talk about alveolar ventilation. Essentially, alveolar ventilation is the amount of air that makes it to the alveoli that is available for gas exchange. So there are a lot of factors that determine how much air makes it through the airway and into the alveoli. Here I've got kind of a little branch of the lower airway, branching through the carina to the main bronchus, into the bronchioles, down into alveoli or alveolar sacs there. So of these things that we need to worry about, or that we need to know, is our definitions of tidal volume. So a tidal volume of the lungs is the amount of air we inhale with each breath, or with one breath. Okay, how much air do we take in with one breath? That is our tidal volume. We need to know dead space. What is dead space? It is the portion of the airway that is not available for gas exchange. So, for example, the trachea, the main bronchus, the bronchioles, until they break down into the alveolar sacs and you have that capillary bed around the alveolar sac, that is all dead space. That is all air that is drawn in that does nothing more than sit in this space for that second before it's pushed back out. Our vital capacity is the maximum amount of air you can expel from the lungs after maximum inhalation. So amount of air expelled from lungs the maximum amount of air expelled from the lungs after maximum inhalation. So those of you with asthma or with any breathing disorders, or kids with asthma or any breathing disorder, have had this tested and have it tested on a regular basis because they need to know the capacities of the lungs. They need to know if you are increasing, decreasing, staying the same. It's all important. So the max amount of air expelled from the lungs after a maximum inhalation. So as hard as you can push it down, as much as you can expel. Take the biggest, deepest breath you can and exhale as hard, fast, and as deep as you can. That is your vital capacity. That is the maximum amount of air you can hold within the chest cavity, within the lung tissue, in the alveoli, and the maximum amount of air that you can exhale from your lungs. We need to know our respiratory rate. Or our ventilation rate. This is how many breaths you take in a minute. depending on what you're doing. Many people can get this tested at 2 different times. You get it tested at rest, and you get it tested at exercise, depending on what may be a problem or what you're having checked, or so on and so forth. Generally, we test it as soon as we check respiratory rate, as soon as we arrive on a patient, and then we ask questions as to why it may be increased. Did they just exercise? Now they're lightheaded. They did harder, more than they expected. Are they having chest pain and they're anxious? Are they having episode where there's air hunger? What are the many different things that will affect your respiratory rate? And we have minute volume. And what is our minute volume? Our minute volume is the amount of gas inhaled or exhaled from the lungs in 1 minute. So the amount of air inhaled or exhaled in 1 minute. So that's why we need to know, to figure minute volume, we need to know respiratory rate. To know minute volume, we need to know respiratory rate and tidal volume, so that we know what amount of air to multiply by the number of breaths within the 1 minute. Residual volume. And finally, our residual volume is the amount of air remaining in the lungs after a maximum exhalation. So the amount of air remaining in the lungs after maximum exhalation. So when you're doing the vital capacity test, you're also doing a residual volume test. So you take in, they measure the amount of air you draw in. And then after the maximum amount of effort to exhale, they subtract and get the difference, which is your residual volume, which is what's helping to hold the alveoli open and keeping them from collapsing, along with the surfactant within the lungs that help keep that open. Because if they stuck together, it'd be like a balloon that gets wet on the inside, and you try to blow it up, and there's no way of getting that to open up, or it's very difficult, very hard. Imagine if we had to do that every time we took a breath. That is the basics of the mechanics, or the mechanics of ventilation.